Our today's session is focused on a very important infectious agent that has caused many outbreaks and pandemics in the past and still considered to be one of the major cause of worldwide death due to this infection. As you know that we're going to talk about the virus that causes influenza, and according to the WHO during 2019, there has been almost over 3,000 deaths with this organism. So still a major important infectious particle that causes huge number of mortality or morbidity in the entire world. Now this influenza virus, this belongs to a group of microorganisms which is called as the ORTHOMYXOVIRUses. And this is the only member of the ORTHOMYXOVIRUS. This means that the ORTHOMYXOVIRUS is comprised of just single infectious agent, which is known as influenza. Now, if you look at the diagram over here, it is the electronic picture of influenza virus. And the RNA of the influenza virus, it is segmented RNA, it's negative polarity RNA. And then is another microgram that has been published by the European Journal and indicate that these structures which are present on the spike of the virus, they are the real knives that causes damage to the human cell. Now, we will discuss the properties of the two important group. One is the ORTHOMYXOVIRUses and the other one is the PARAMYXOVIRUses. Now, the term mixo refers to the observation that these viruses, they interact with the mucin, which is glycoprotein on the surface of the cell. So because of their affinity towards the surface of mucin-rich cell, we call them the myxoviruses. We have two groups of viruses, the ORTHOMYXOVIRUses and PARAMYXOVIRUses. Well, let's compare both of these group of viruses. If you look at the properties, the ORTHOMYXOVIRUses comprise of just one group of organisms, what we call as the influenza. And the influenza have three subtypes, what we call the influenza A, influenza B, and influenza C. Whereas the PARAMYXOVIRUS is comprised of four major important viral agents: the measles, the mumps, the respiratory syncytial viruses, and the parainfluenza viruses. So both are the myxoviruses, both have the affinity for the mucin of the respiratory tract, and the influenza A, B, C belongs to the ortho group, whereas the measles, mumps, respiratory syncytial virus, and parainfluenza, they belong to the paramyxoviruses. Now, the genome of the ortho and paramyxoviruses, if we compare this, this is segmented as we have seen. The genome of influenza virus is segmented. It's a single stranded RNA, and the RNA is of negative polarity. We'll discuss this in details. Whereas compared to that of the paramyxoviruses, this is a non-segmented virus. The genome is non-segmented. It is again a single-stranded RNA virus, again of negative polarity. So with respect to the differences in the genome of the ORTHOMYXOVIRUses, there is not much difference except that the genome of influenza virus is unsegmented. It is segmented, sorry, it has just 8 segments compared to that of a single segment of the paramyxoviruses. The capsid or the symmetry of the viruses in both of these cases is the helical. Both of them, they have the envelope. Forget about the size, although you see both are almost the same size. Now, the surface spikes, this is again a very important difference between the ortho and myxoviruses. The surface spikes have both the hemagglutinin and neuraminidase on different spikes compared to that of the paramyxoviruses, which includes measles, mumps, respiratory syncytial viruses, and parainfluenza. The hemagglutinin and neuraminidase receptors, they are present on the same spike. This again is very, very important. The giant cells, they are formed in case of paramyxoviruses, whereas there is no giant cell formation in case of influenza virus. So two major differences that you have to keep in mind for the rest of your life, that the genome of influenza virus is segmented. It has 8 segments, single-stranded negative polarity RNA compared to that of the non-segmented genome of the measles, mumps, respiratory syncytial virus, and parainfluenza that has negative polarity RNA. And both, in case of influenza virus, the hemagglutinin and neuraminidase receptors, they are on the same spikes, whereas in case of measles, mumps, RV, RSV, and parainfluenza, they are on the same spike, they're on the different spike. Now, what is the significance of the negative polarity RNA? Now, in order to make the proteins, the negative polarity RNA, what we call it the negative strand RNA, it has to be changed into the mRNA so that it should make the protein of its choice. Now, what have all those viruses which have negative polarity single-stranded RNA, they should have their RNA-dependent RNA polymerase, so that their RNA-dependent polymerase, after entering into the human cell, will convert this negative stranded RNA into the positive stranded RNA, what we call the mRNA, and that will be then making proteins. So these were the major differences between the two groups of ortho and paramyxoviruses. Now, what is influenza virus, or what we commonly called as flu? Flu is nothing, it is just a febrile respiratory disease with the symptoms that are maybe of, you see the systemic symptoms, and it is caused by a variety of other organisms. Often, inaccurately, they are collectively termed as the flu. So influenza virus is not the sole source of infection that causes flu-like symptoms. Many other viruses are there. There are almost 14 viruses. Out of these 14 viruses, the 9 viruses, they belong to the RNA viruses group, the 5 belong to the DNA virus group. So there are just within the viral community, we have 14 different viruses that causes influenza. So influenza is a generalized, that causes flu, it's a generalized term given to the respiratory systemic infection caused by the viruses. Now, what is a true influenza? When we talk about the true influenza is caused by influenza virus A. Now, the influenza virus A is the major source of pandemics in the world that has occurred many in the past. This influenza virus A pandemic, it can occur after 20 years, 30 years, 40 years. Now, this pandemic, it is mostly because of the variation in the genome of the influenza A that contains new hemagglutinin spikes that enters into the human population. So the human population has not been previously exposed to these mutant spikes of hemagglutinin. So the major outbreaks, they occur every year as a common source. So every year that we saw the influenza virus, it is mostly because of the influenza A virus. So the pandemic can be common every year outbreaks of influenza that we observe each year during the winter season throughout the world. They are mostly because of the influenza A. Now, the influenza B virus, it also causes major outbreaks, but not that common compared to that of the influenza A. This means that still influenza A virus is the major source of seasonal outbreaks of the influenza. The influenza C virus, it's much wider respiratory infections, and the infection with this influenza virus goes almost unnoticed. So when we talk about the true influenza, we talk about the influenza virus C. That is the main source of seasonal outbreaks, and it has been responsible for the major pandemics that has occurred in the world. Of course, you see some cases of influenza B. They also are involved in the major outbreaks, particularly in the winter season, but it's not that common. C is rarely involved and causes mild respiratory tract infections. Now, what is the impact of the influenza? Just see that what damage has really done this agent in the past. Now, if you go back into the 1918 to 1919, there was a Spanish flu, and that causes 500,000 deaths in the United States. So this death toll is more than the number of the total death that America has faced in World War I, World War II, Korean War, and even in the Vietnam Wars. There was more than 22 million worldwide death. And there was another outbreak that was the Asian flu in 1957-58, and there was almost over 70,000 deaths in the United States. Now, we have, in the recent era, we have seen the bird flu that we had the epidemic in 1997. This is what we call as the H5N1 bird flu. We'll let you know in the coming slide what is H5N1. And then we have again another, you see in the 2009, it was because of the influenza strain H1N1. it was swine origin influenza virus. It was transmitted from the swine. This 97 flu, it was the bird flu. It was transmitted by from the poultry. Now, in the United States, as an average, still you see there are more than 36,000 deaths every year, and there are more than 100,000 hospitalizations each year. So this is just to realize you the impact of the influenza. It is not that simple disease. Once it was really came into the world the first time back in 1918, it was really a panic like the corona panic that we have nowadays. So it has huge morbidity and mortality, huge losses in lives, huge losses economically, but we have to live with this microorganism, and we are living with it. The same way maybe we'll be able to live with the corona in the coming years. Now, the continuity with the influenza impact the recent increase in the morbidity and the mortality of the influenza, and that would also contribute towards the coronavirus, is mostly because of the elderly people. The more elderly people, they're more involved, and more immunocompromised, immunosuppressed or immunocompromised patient, because of the advent of the immunotherapy for the cancer patient and the more sophisticated diagnostic procedures that has brought the number of, you see, the underhidden diseases to more extent. Of course, the high-risk neonates, they are also on stake. So the elderly people, immunocompromised individuals, and neonates, which are on high risk for this disease. Let's talk exclusively now to the orthomyxoviruses. We'll talk about the important properties of the orthomyxoviruses. As we said in the very comparison with the myxoviruses, that the influenza viruses belongs to the category of orthomyxoviruses. They are segmented single-stranded genome. Their genetic makeup is of RNA in nature. The RNA is of single-stranded, and it is a negative polarity RNA. That means it has to change into the positive polarity RNA before it enters into the replication process within the host cell. The symmetry is nucleocapsid is of helical symmetry, and it is an enveloped virus, and the enveloped is made up of lipoproteins. Negative polarity genome, and the negative polarity genome is not infectious until unless this negative polarity genome is converted into the positive polarity genome. Or in other words, the negative standard RNA is converted into the positive standard mRNA. The organism, the virus is not infectious. And it happens once the virus enters in the host cells, and then it started replication. And during the process of replication, it uses RNA-dependent RNA polymerase to convert the negative polarity RNA into the positive polarity mRNA. Now, the RNA-dependent RNA polymerase, it transcribes into mRNA. This means that the virus is equipped with the necessary equipment that is required to change the negative standard RNA into positive standard RNA. It carries its own RNA-dependent RNA polymerase. So that RNA polymerase, it transcribes the negative standard RNA into the mRNA, and then it changes the proteins. Now, this is very, very important. I'll take some minutes onto this slide. And if you really understand this slide, then you will be able to understand the pathogenesis of and the diagnosis of the influenza virus. Now, if you look at this slide, we have over here, I'm sorry for this, we have the hemagglutinin spikes, and we have the neuraminidase spikes. As I said in the very beginning, that in orthomyxoviruses, the hemagglutinin and neuraminidase, they are on these separate spikes. Whereas in case of paramyxoviruses, they both are on the same spike. Now, one difference. Now, hemagglutinin, it is of 16 different types. The hemagglutinin shows, you see, the antigenic differences in at least 16 different types, whereas the neuraminidase has 9 different antigenic types. Now, when we combine both of these, the probability, it goes into thousands. So the influenza virus, it has a separate hemagglutinin, which is of 16 different types, and each type is antigenically different. It has 9 different neuraminidase spikes, and they are again antigenically different. So when there is occurrence or probability, it goes in thousands of cells. Now, cell also, as you see, the bacteria has also, the virus has also the helical nucleocapsid. It has a lipid bilayer membrane envelope. It has a polymerase complex, and it has a protein that we see over here. Now, the subtypes of the influenza virus, they are based on to the hemagglutinin and neuraminidase proteins. This is very, very important to understand. So the envelope is covered with the two different types of spikes, the hemagglutinin and neuraminidase, and 16 antigenically different types of hemagglutinin. And these hemagglutinin, they agglutinate the RBCs. And this agglutination potential of the hemagglutinin, it is used for the diagnosis of the hemagglutinin in the laboratory. This is what we call as the hemagglutinin inhibition test. This is what we will use for this purpose. Now, if you look at this, the hemagglutinin spikes, they bind to the cell surface receptors, which are, of course, it's a neuraminidase acid or the salicylic acid, and they initiate the infection. After binding the receptors, they initiate the infection, and they agglutinate. They have the ability to agglutinate the RBCs, and this agglutination ability of this agglutinin, it has been exploited by the virologists for the identification of this virus in the laboratory, and a test is performed, which is known as hemagglutination inhibition test, HIT. Now, these HIs, they target the neutralizing antibodies and they inhibit the infection of the cells. And these hemagglutinin, they function in the beginning of the infection. Where in the later stage of the infections, the neuraminidase, they're starting effect, and they cleave the numeric acid, and then they release the progeny viruses. So once the virus enters, it replicates, and the progeny variants has to be released. Then the neuraminidase, it comes into action, and it cleaves the cells and releases the progeny viruses. It degrades the protective layer of the respiratory tract mucus and enhances the access to the respiratory cells, and this function at the end of the cells. So though hemagglutinin acts in the beginning, neuraminidase acts at the end. Hemagglutinin binds, enters, and produces antibodies, and whereas the neuraminidase, they lyse or cleave the cell to release the progeny variants. Now, the influenza virus A, it shows changes in the antigenicity of the hemagglutinin and neuraminidase protein. This is important. This is important. The influenza virus C is continuously changing its antigenicity of the hemagglutinin and neuraminidase protein. Now, this frequent change in antigenic potential of this virus makes vaccines difficult to work and makes virologists difficult to make vaccine for every season outbreak in winter. Now, these variations are genetic changes in the antigenicity of the hemagglutinin and neuraminidase proteins. They contribute to devastating pandemics or worldwide, you see the epidemics that we see every year. Now, there are two types of antigenic changes, and we have to understand this very. One is the antigenic shift. The other one is the antigenic drift. This means that two types of antigenic changes, namely antigenic shift and antigenic drift, it occurs continuously in the antigenic potential of the hemagglutinin and neuraminidase proteins. This means that HA and NA spikes, they are continuously changing or mutating their antigenic potential. And based on these changes, we have two types of mutations or changes, what we call as the changing and antigenic change. One is the shift and the other one is the drift. Now, let's see what is the difference between the shift and the drift. The antigenic shift is the major change. This is the major change that really changed the entire genome, and this change is responsible for the worldwide epidemics and pandemics of the influenza virus. This major change is based on the reassortment of the segment of genomic RNA. The RNA, it is incorporated into the RNA. Now, where does the other RNA comes from? We will let you know. The entire segment of the RNA is changed. Such a huge mutation that there's almost reassortment of the segment of the genome of the RNA, and this genome of RNA is exchanged, each one coding for a single protein. So entire genetic makeup is changed by the reassortment of the genome of RNA. Now, this means that there are new hemagglutinin and new neuraminidase proteins, they are formed. Now, the population, the human population, they have not been exposed previously with these newly formed hemagglutinin and neuraminidase spikes. So the pre-existing antibodies, they are not protective against the newly formed hemagglutinin neuraminidase proteins. That is why we can get the epidemic, worldwide epidemic or a pandemic. So the antigenic shift is responsible for the major reassortment of the segment of genome, and it results in the production of new human HA and NA proteins, which are new to the human body, and the human body has not been previously exposed to this, or we are not having the pre-existing antibodies in it that can be neutralizing by this. So we can have the pandemic. Now, there is an antigenic shift. This is not the major change. Antigenic drift is not the major change. Shift is the major change. This is a minor change on the mutation in the genomic RNA. And these minor changes go on accumulating onto the HA and NA receptors or spikes. And the immune response is no longer fully protected. And the sporadic outbreaks or limited epidemics or limited cases of the influenza they occur. So antigenic shift is responsible for the major worldwide epidemics and pandemics, whereas the antigenic drift is not that much common. It is responsible for the sporadic cases or the very limited epidemics in an area. Now, what is the group and type specific antigens? The internal ribonucleoprotein, which is the group specific, and this distinguishes the influenza into A, influenza B, and influenza C. This means that the influenza A, B, C classification is based on to the differences on the ribonucleoprotein, which is group specific. The influenza A group specific riboprotein will not provide protection against influenza B. Influenza B will not provide protection against C, and like vice versa. The hemagglutinin and neuraminidase receptor, these are the type specific proteins, and they are located on the surface as we have seen. Antibodies against the hemagglutinin neutralizes infectivity and it prevents the disease. Now, when there is hemagglutinin action, hemagglutinin, the antibodies are performed, and these antibodies, they neutralize the infectivity of the hemagglutinin, so that there will be no more disease. Now, antibody against the neuraminidase, they are located internally. They does not prevent, because they're internally, they does not prevent, but does reduce the decreasing the amount of the viruses. So HA antibodies are protective, NA antibodies are not protective because they are located internally, but they can play a role in reducing or decreasing the amount of the virus in the body. Now the question arises, where do the new hemagglutinin and neuraminidase it comes? Now you see, we have the human influenza virus carried by the human. We have the chicken influenza virus, for example, which is carried by the chicken. Now, both of these viruses, they go to the lung cells, and then the assortment of RNA genome segment takes place, and a new strain of the influenza virus comes into existence. So this is what we call as the antigenic shift in the influenza virus. The human strains of influenza virus, it contains the genes that code for the antigens of hemagglutinin, and it combined with the antigen of the hemagglutinin of the bird viruses, of the swine viruses, and then there is a major shift, and that leads to the pandemic or epidemic of the influenza virus. So that's why we have the bird flu viruses in 1997, and we have you see another type of viruses back in 2019. Now, new H&E comes from, we have seen that they come from birds, they come from swine, they can come from horses. We have 16 types of HA, 9 types, and all circulates on the birds, and you don't know that whichever will come to the human and will resort it into the genome of the human strain of influenza virus, and they will cause disease in the form of epidemic or worldwide pandemic. Sorry. Now, the transmission of the disease is, as we have seen in case of coronaviruses, it is aerosol, and we have almost, you see, from 100,000 to 10 million variants in per drop of aerosol. The incubation period for the virus is 18 to 72 hours, and the virus is set in the sneezes and in all of the other coughing and all that. The epidemic immunity of influenza A virus, it depends upon the antigenic change, as we know that the major change in the hemagglutinin or neuraminidase, it will cause the epidemic. Particularly the major shift in the antigenic shift, or the minor is the antigenic drift. So when there is antigenic shift, there is every possibility that we have a new strain of influenza A, and that will cause you the disease. Now the antigenic shift, it appears infrequently, and we have seen one back in 1968, H9, H3, N9. Now you understand the hemagglutinin 3 and neuraminidase 2. And we have 16 hemagglutinin, we have 9 neuraminidase. And when you combine, when we see the probability, it comes into you see the hundreds. Now the antigenic shift, it virtually occurs every year. That's why you see we have every year we have the incidence of influenza. The vaccine that is being prepared for the influenza, it is from the prevailing strain of the influenza, and that is only effective for that season. In the next season, we will have another mutation, and we will have a new vaccines. So the vaccine does not provide protection for the long period of time. It is just a seasonal vaccine, and the vaccine is prepared from the prevalent strain at that season. Now, when worldwide epidemics occurs, there is sufficient change in the antigenicity, and the pre-existing immunity, it is no more effective because the individual has not been exposed to this antigenic change. So the new HA and NA spikes are there that needs to be entered and exposure of the body, the immune system, to make the antibodies against those specific receptors or spikes. The antigenicity of influenza B, it undergoes antigenic drift, not a shift, so there's minor chances, there's localized epidemics, sporadic cases, and the antigenic changes of influenza B less dramatic, less frequent than influenza A. That's why we have the frequent epidemics with influenza A, because the antigenic shift is very frequent in influenza A. The influenza B hardly go into that. We have never seen antigenic shift in case of influenza C, very rare. So because the influenza A virus undergoes excessive mutation, and there is excessive change in the antigenicity of the neuraminidase and hemagglutinin spikes, so we have the frequent epidemics and pandemics with influenza A virus. Why we not have influenza B pandemics? As I said, there is no major shift recorded. No animal reservoir is known. So there is least possibility of the assortment of the genome of bird or swine into the human viral. So we are not having the pandemics of the B virus. The symptoms, they are very generalized symptoms. So you can have the fever, headache. There is myalgia because of the production of cytokines, cough, rhinitis, and some irritation in the eyes is there. So generalized signs and symptoms. Normally you don't have the temperature, but sometimes you can have a mild temperature, not more than 100 degrees. The pathogenesis, if you understand really the structure of the viral particles, and you are now very much versed with the hemagglutinin and neuraminidase receptors, their locations, their antigenic changes, and then you can easily comprehend the pathogenesis. What the neuraminidase do, it degrade the productive mucous layer, as we already said. This, after degrading the mucous layer, the virus gain access to the cells of the upper and lower respiratory tract, and this infection is limited due to the proteases that cleave the hemagglutinin, which is present in the respiratory tract. The severity of the disease, it depends upon the very young people, the elderly, immunocompromised, and those having lungs or heart diseases. They are exposed to more severe kind of infection and symptoms with this infection. Now, the complications, we can have the pulmonary complications of influenza virus, we can have the non-pulmonary complications. Now, in the pulmonary complications, primarily the influenza virus pneumonia, if you do not take care in the very beginning, it can be having with the secondary bacterial infections, particularly with the Staphylococcus pneumoniae, Staphylococcus aureus, and Haemophilus influenza. That's why you see the antimicrobial drug are least effective against the virus. But in order to overcome the secondary bacterial infections of the Staphylococcus and Staphylococcus organism, along with that of the Haemophilus influenza, we have to go for the antimicrobial therapy in the initial stage. Some non-pulmonary complications can also arise, like the myositis. This is very rare in children, less than you see, and more or less more with the type B. The cardiac complications. The recent studies report some individuals can enter into the encephalopathies, the young adults, and there is liver and CNS involvement, what we call as the Reye syndromes, and there is peripheral nerve system involvement, what we call as the Guillian-Barré syndrome. Now, what are all these two? Now, Reye syndromes, they are, you see, the pathological conditions in which the livers become fatty, the fat deposits in the liver, and there is edema in the brain, and there is vomiting, lethargy, and coma. Mostly, you see, the high factors are the youth, the newly born babies, and it can be with other viral infections apart from influenza. The chickenpox can also lead to the syndrome, and aspirin is also a predisposing factor to the Reye syndromes in the babies. That's why you see the aspirin in babies' respiratory tract infections or influenza is not recommended, because it elicits the different immune response that leads to the different systems in the babies. So that's why we depend on the Panadol compared to that of the aspirin. The Guillain-Barré syndrome is, again, you see, it has seen in 1976 swine flu vaccines. The vaccine, it was an attenuated vaccine, and because of the incomplete attenuation, the virus was not fully inactivated. It still has its pathogenicity, and there was about, 35,000 doses, and we have about 350 cases of this kind of syndromes, and there were about 28 deaths. So the recent vaccines, they are low risk. They are differently designed vaccine. This was not because of the disease, but because of the vaccines that was not fully inactivated. So we'll have to keep in mind these two things. The mortality with influenza virus is mostly associated with with the bacterial pneumonia and the cardiac failure. The influenza virus itself is not that much dangerous, but when it is associated with the bacterial pneumonia, and if this occurs in the elderly patient and the immunocompromised individuals, then you see the mortality rate, it goes high. 90% of that, they have been mostly recorded in case of influenza virus over the age of 65 years. So old age people who are debilitated, who are immunocompromised, who are on various steroid therapy and cancer therapy, they are more prone, and the mortality rate is high in such individuals. How we can get protection against the reinfection of this organism? Of course, we see that the IgG and the IgE antibodies, G are less efficient but last longer. The antibodies both to the HA and NA, they are important, and we will have to go for this, and they can neutralize the circulating antibodies. So the vaccines are there, and we can get protected ourselves from the reinfection. The diagnosis of the viral diseases, it is mostly, you see, depend upon the isolation we can do, but we do not know how to do. The virus detection and isolation is a generalized considered procedure, but it takes a long time. It is done in the specialized virology laboratory because we need living culture to grow. We take the swab from the nose and the throat, and we can do with the PCR or fluorescent antibody assay. Tissue cultures, we can go inoculation, but the prefer is the PCR. It's sensitive and specific. We do have this rapid test, what we call as the detection of viral antigen by using the specific monoclonal antibodies. There are some commercial kits available, what we call it the flu O1A, the QuickView, and StatFlu. So these are there are many more. There are many more. They're just to give the name. So the commercially available monoclonal antibodies are available that are used to detect the prevailing antigen. These are rapid tests. Their sensitivity and specificity has been established, but still the false positive and false negative results can occur. But because we use the monoclonal antibodies, so the incidence of false positive results or false negative results, they become very, very low. So we can depend on the monoclonal antibody because they are highly selective monoclonal. They have been derived from the one clone. So there is least possibility of deviation or mutation. So we can have the specific result with this, but still you see chances are there. The surveillance, it was done in the area where you see they use the vaccines, normally done in the United States in different areas, and they collect the prevalent strains and they make the vaccines. Such practices are not being done in Pakistan. Unfortunately, we are not using the vaccine. We do import some of the vaccine, and that is creating another problem because you are importing the organism. Importing the vaccines means that you are importing the organism. Maybe that organism is not initially present in our society, and we are introducing a different strains of the virus in our environment. So we can face the consequences though. The vaccine is given best on the just based on the guess of main antigenic types available or prevalent in the specific environment. Currently, we have type A H1N1, type A H3N2, type B. These are normally used in the United States. Now, each year, the vaccine is chosen with variants of each subtype that is the best use for the optimal protection. So we'll have to select, we'll have to survey and find and isolate the prevalent or prevailing virus and make the virus, make the vaccine against that specific prevailing virus in the society or in the environment. The virus, inactivated viruses, egg-grown viruses, they most are done. Subunit vaccine for children is available. There is reassortment right vaccine that was approved in 2003. It's quite safe. For healthy persons, those are not a risk for complications for influenza infections. For the age of 5 to 49 years, there is hardly need of vaccine. But those who are on risk, elderly patient, old home residents, cancerous individuals, steroid therapy individuals, they are in need of vaccine. Now the treatment of drugs are available, but we hardly choose one. Maybe we'll have to go for those individuals who are immunocompromised. The Remantadine is there, and this is effective only in the type A. Then we have another Remantadine that is effective on type A only. Then Zemavir is there, Oscillatomivir is there. So some of them, they act on to the type 1, then type A and type B. But they mostly act on the other two, the Zanamivir, it acts on the neuraminidase, it acts on the M2 receptors. All drugs, you see, all drugs needs to be given in early detection, particularly for the immunocompromised individuals. Now we have other types of influenza. We have the avian influenza, we have the swine influenza. What is the avian influenza virus infection in the human? We have seen this avian influenza epidemic back in 1997. It was with the H5N1 influenza A. Then we have another one that was in 2003, 2004. It was again with the H5N1, and there were thousands of birds, chicken, they were killed all across the country, particularly in the forest Asia, like in Philippines and in Vietnam and in China and part of Pakistan also. And then again, H5N1 person to person spread is very rare because we need the assortment of avian influenza strain with the human influenza strain to get this kind of epidemics. But remains a major concern. Still, person to person spread is a still major concern. We will have to look into very seriously. Now, if free assortment with the humans adopter strains occur, then there is chances. Unfortunately, we the human beings are lucky. There is no reassortment of human to human strain. But once the reassortment of the human strain, adopter strain occurs, then the epidemics would become a real problem for the human. So far, the reassortment is from the avian influenza strain or from the swine influenza strain into the human strains. So maybe you can say it's a zoonotic virus then. Human to human transmission has yet not been documented. Transmission means the reassortment of the genome of the human influenza virus of one type with the reassortment of the human influenza virus strain of the other types. So this has not been there. So we are lucky enough that we are not having that faster spread of human influenza infection. Now, don't cry because it's over. Smile because it has happened. Thank you very much. I hope you enjoyed this time. And this is a real important with respect to the academic point of view, because we will sometime compare the corona infection with that of influenza infection, maybe at the end of the session when we will be finishing the RNA viruses. We'll continue our discussion next time on to the RNA viruses. Thank you very much.